Good evening, ladies and gentlemen. If you can hear me, sorry for the technical challenges that we've had with sharing the presentation. So this evening webinar presentation with us, we have Dr. Gerald Moniz, who is a consultant anesthesiologist at the Nairobi Hospital. He's had a few attachments in critical care and even pediatric anesthesia at the University of Hull and Leeds in the UK. And he's going to take us through a new era of multimodal analgesia and opioid-sparing analgesia. Before he makes his remarks, we have a few announcements in the house. You're welcome to this webinar, and we appreciate everyone that was involved in organizing the webinar, all the participants, both Kenyan and non-Kenyan, and also our able partners, which is from Harley's company. So if you have any questions, please put them in the chat box, and it will be addressed once Dr. Mann is present. Recordings are in the KSA website, Facebook, and YouTube. CPD points are usually provided for the doctors, and for the others and non-Kenyan participants, they'll be sent participation certificate. And for that, we apologize that the last week's certificates were not sent in good time. The administrator was out of office for a bit, but in the course of the week, you'll be sent both this current presentation and the one that was done last. Dr. Moniz.
Hello, good evening.
Good evening.
Can you hear me?
Yes, Dr. Ari, please go ahead.
Yeah. So today we are going to talk about multimodal analgesics with a view to sparing opioids. We know that opioids are the mainstay of intra and post-operative analgesia, and people are trying to move away from opioids for the simple reason that they do have quite a number of side effects, which end up both lengthening patient stay in hospital, and sometimes they have other side effects which lead to other complications. So next slide. So first we'll just talk briefly about the broad groups of analgesia. We have the opioids, which are about 4 or 5 which are commonly used. We have the weak opioids, something like tramadol. We have the non-steroidal anti-inflammatory drugs, which are quite a number, but they all share the same advantages and disadvantages. Then we have paracetamol, which is a simple drug. It's quite safe, but it has its limitations. And it's usually used as in multimodal analgesia. It cannot be used alone. And lastly, we have the other analgesics, which is what we are going to talk a little bit more about today. These are centrally acting analgesics. They do not fall in either NSAIDs. They are non-opioids. They do not cause any respiratory depression. And that is what we are trying to talk about today. That they are sponsored by our company, our good friend Harley's. So we come to opioids. We'll go through this quite quickly. The common ones used here in this country is morphine at the dose of 10 milligrams subcute or IM, that is for an adult, and 2.5 to 5 milligrams IV for adults. All these doses are for adults. For children, you'd have to decrease the dose according to the body weight. Fentanyl is usually 1 to 3 micrograms per kilogram, slowly IV, and then you add it as required. Pethidine can be given in a dose of 50 to 100 milligram IM or subcute, or 25 to 50 milligrams IV. Oxycodone is usually used as 1 to 10 milligrams IV over 10 minutes, or you can give it as a continuous infusion of 2 milligrams per hour. Oxycodone can also be given subcutaneously. It is never given intramuscularly. It should not be given intramuscularly. And lastly, we have Remy Fentanyl, which we usually use in theater or in intensive care only for patients who are being ventilated. The reason is that it has a very, very strong respiratory blocking effect, so it cannot be used in a spontaneously breathing patient. Never make that mistake. Next. These are the weak opioids. Many of us have been using it also. Tramadol is the one which comes to mind. It's a strong analgesic. The disadvantage being that it does cause slightly more nausea, vomiting, constipation, dry mouth. Sometimes in men particularly, it can cause difficulties in passing urine. And a few patients have reported unusual CNS symptoms with confusion and delusions, even in normal doses. Now, it also has a tendency to cause seizures. So anybody with head injury or previous history of seizures, or who is actually on anti-epileptic drugs, you should treat it with caution. Maybe use it in a low dose, or if not, if you can avoid it, the better. And then, being a weak opioid, it also has a degree of addiction, not as severe as the strong opioids, but it is still there. Although it is not kept as a in the DDA cupboard, it still has addiction possibility. Next slide. Now, what are the advantages of opioids? They are very potent analgesics. They have a mild sedative effect, which is sometimes a good thing for patients who are very anxious. And they are associated with a high degree of patient satisfaction. After surgery and when they are going home, patients feel that they have been treated well. So that is why a lot of us use it quite heavily. Now, next slide. Unfortunately, they also have quite a number of disadvantages. Next. Next slide. Yeah, the disadvantages of opioids, you can see, there are many, but the main ones which are always coming to our mind and which always give us a bit of problem in anesthesia and post-operative management is respiratory depression. What it does, it decreases the respiratory rate. It does not affect the tidal volume too much, but the rates are very, very slow. And because of that, you end up getting quite a bit of carbon dioxide retention. If you're monitoring the carbon dioxide, you'll actually see carbon dioxide levels rise quite high. Oxygen levels usually do not get affected by opioids, but the carbon dioxide is the one which gets affected. The next thing they can cause is hypotension. Whether you've given it IV or IM, they do cause hypotension unless you have actually reduced the dose. Another problem is nausea and vomiting. Then next one is spasmogenic. They're usually spasmogenic both to the ureters and to the sphincter of Oddi. So people who are having gallstones or stones in the bile duct, or have had major surgery in the biliary area, you would try to keep the dose on the lower side. Or if you have no choice, you give it with an antispasmodic, something like Buscopan. It also can cause ureteric spasm, and people again having stones in the ureters who have not yet had surgery could get into excruciating pain. Now, you also have to avoid opioids in a patient who is already starting off with supraventricular tachycardias. They can make it much worse, and then you'll have a lot of problem trying to revert back to a sinus rhythm. So if at all you have to use them very sparingly and be prepared to treat the SVT if it does turn up. A next problem, which is a big, big problem, and that's why we are looking for alternatives to opioids, is patients with major abdominal surgery. When you've done a lot of intestinal work, they do cause a paralytic ileus. And this gives us a lot of problem in the post-operative period in terms of bowel sounds taking long time, distension of the intestines. And you know, when you get distension, even the abdominal wound starts getting under a lot of pressure, and the pain, it's actually a vicious cycle. So there are ways now of doing these things, almost getting away from opioids and getting your bowel sounds back quickly, allowing patients to take liquids earlier and getting out of bed earlier. And all these things will be done by trying to stay on opioids. And that is why we are looking for all these new things which can be used. Now, also, we tend to avoid opioids in patients with head injuries or with raised intracranial pressure. They do make it worse. There's no question about that. And if at all you're going to use it in such a patient, that patient should be ventilated, intubated, and you should be either going for surgery or you have just finished surgery, and then you can use it because you have decompressed that patient and the raised intracranial pressure may not be too much of a problem. Also, in severe renal or hepatic disease, you should either avoid it or use very minimal doses, if at all. And that is left to your discretion, but particularly with hepatic disease, because it is not going to be metabolized properly and its effect is going to last for a long time. And sometimes you'll even reverse the effect of the opioid. And you know that the reversal agents like naloxone are short acting. So you'll reverse and you'll think the patient is okay, only for the initial drug to come back, bounce back when you're not even around. And it can cause a lot of problems, either in the recovery rooms or even in the ward when the patient has gone back. A patient who has been left talking, has been reversed, can go back and the effect can come back of the opioid. Remembering that the opioids are longer lasting than the reversal, unless you're going to put somebody on an infusion of reversal of naloxone or nalorphine. Then there's the other disadvantages. Disadvantage is addiction, both to patients who have been operated frequently and also to the staff. And lastly, I don't know if you've noticed that there is a definite what is called hyperalgesia. When you withdraw an opioid suddenly, there is hyperalgesia. They get into a situation where they start requiring a lot of painkillers and you'll actually be chasing yourself. This used to happen when we started using Remy Fentanyl in the beginning. These patients were very good in the theater, but at the moment they came to the recovery room, you could find them becoming very restless and in a lot of pain. And that is what is called hyperalgesia. So you have to look for ways of, if you're using opioids as your main painkillers, look for ways of dealing with hyperalgesia. And the other way out of that is to use minimal opioids and use other drugs which deal with the hyperalgesia right from the beginning. Next. Another big group is the non-steroidal anti-inflammatory drugs. These are also very good drugs. They're very easily available. The good thing about them, I'll just tell you their names. Diclofenac usually goes under trade names of Voltaren, Olfen, and Dynapa. There's Ketorolac, which goes under the trade name of Rolac. Lonoxicam, which goes under the trade name of Zifo. And Dexketoprofen, which goes under the trade name of Ketes. All these are non-steroidal and anti-inflammatory drugs. I'm not going to discuss each one and every one of them. Maybe we can do that at another sitting. But we can go to the next slide. I'll tell you the advantages and the disadvantages. Then you choose for yourself. The advantage of non-steroidals is that they are both anti-inflammatory and analgesic properties, so that the help with the swelling and post-op pain is quite good. Pain relief is quite good. Now, the disadvantages, this means where we should avoid these patients completely, these things, or treat them extremely carefully, because you can be blamed in the end that you have caused somebody to get into renal failure or his blood pressure to become uncontrollable. So remember, we are working as a big team, and many of the patients, particularly in private hospitals, are already coming to you with very many comorbidities. I can't remember the last time I did a normal patient without any comorbidity and could freely use any drug I wanted. Most of them come with something or the other, and we don't want to make them worse. For patients with established cardiovascular disease, you have to be cautious. If the hypertension is not well controlled, don't use these because they will increase the blood pressure. If somebody has renal impairment, again, please don't use it. It can cause them to actually go into acute ARF post-operatively. Again, severe hepatic impairment, avoid. Any patient with active peptic ulcer disease or even a history of peptic ulcer disease, or if they've had any history of any type of GIT bleed, do not use. Even if you're going to use a proton pump inhibitor, please don't use this one. Choose any other drug. Also, asthmatics, do not use in asthmatics, please. It can trigger an attack. And because of the platelet interactions, you cannot use them if somebody already has some type of a coagulopathy, or he already has a low platelet count, or thrombocytopathy. That means the platelet count can actually be normal, but they are abnormal platelets. It will make life difficult with bleeding post-operatively, even intra-op. Next slide. Thank you. Next is paracetamol. Everybody is very familiar with this. It is a good analgesic. It's a good antipyretic. It has zero anti-inflammatory effect. It's not doesn't have any anti-inflammatory effect. It is usually insufficient as a single analgesic agent. So it means it's going to be used in multimodal analgesia. It also occasionally causes hypotension when you give it too quickly, but that's something we can easily deal with, especially when we are in theater. But if you are in the ward, you have to tell the nurses to give it slowly. You avoid it in liver disease because, again, it can make it worse. And you have to reduce the dose in infants for the simple reason that their liver is not going to be up to the mark to metabolize it. So dose has to be reduced accordingly. Next slide. Now, this is what we came here to talk about. This is a broad group of it's other analgesics. Nobody knew exactly where to put them. Other analgesics and antipyretics. They are painkillers and they bring down the temperature. They are centrally acting. They are not opioids at all. They do not affect the opioid receptors. And this is what we are going to talk about. It's called Nefopam. The trade name is Accupan in this country, and it comes as 20 milligram vials. Now, what are the advantages of Accupan or Nefopam? It has no respiratory depression, number one. It is a strong analgesic, and it contributes to the anti-hyperalgesic synergy. That means if you've used quite a number of opioids and you have withdrawn them after the end of operation, this one will be very helpful to deal with the hyperalgesia, which sometimes comes due to withdrawal of opioids. This Nefopam and ketamine are two agents which really help with hyperalgesia, and the patients become calm once again. Another place where you'll actually notice that this is very helpful is for people who have come out of ENT surgery and they've had nasal packs put into them. Now, these nasal packs are not only painful, but they are very, very uncomfortable. And no amount of opioid which you're going to give them is going to help them. So this will actually make them tolerate that nasal pack quite a bit better than most of the other analgesics. The other advantage is that it's opioid sparing. You can reduce your dose of opioid and the side effects, hence the side effects of opioids are minimized. It has a very low risk of addiction, and it prevents post-operative shivering. This is another big thing. You've noticed when you give somebody opioids, even when you're doing a cesarean section, they always come out of theater shivering, and it's not that the temperature is low. It's usually the opioids which can cause it, yeah? But this can prevent it. I won't say it will take it away completely, but it reduces the incidence markedly. Next slide. Now, every good drug, there also has a disadvantage. It's not an ideal drug, so these are the disadvantages. If somebody has had a history of seizures or is on anti-epileptic medication or has a severe head injury which has not yet been dealt with surgically, better to avoid it because of the seizure threshold. It could cause seizures, so it's best avoided. Another problem which we have noticed is slightly more in African population for some reason. The male patients end up with some degree of urine retention. Not only a normal male patient, even if his prostate is not enlarged, can end up with a lot of problem to pass urine, and you end up having to put in a catheter for the first 6 hours or 12 hours after surgery. And they don't like that. They'll even tell you, why did you use that drug? The other thing, if somebody has glaucoma, which has not yet been treated, do not use it. It can increase the intraocular pressures. And lastly, it sometimes causes tachycardia and hypertension, not always, but if there's somebody who has a tendency who is already starting off with a faster pulse rate and is already hypertensive, use it with caution. I'm not saying not to use it, but use it at half the dose and watch. Occasional nausea, not as much as opioids, but occasionally it's there, but usually it can be dealt with. Another thing, pain on the injection site, both if you give it fast IV, it will cause you a lot of pain. It has to be given slowly and diluted intravenously, then it is less painful. When it is given intramuscularly, also patients complain of pain on that injection site. So maybe that's something we can start looking whether we can add some local anesthesia in an intramuscular injection and see whether that can help them. Next slide, yeah, good. So this is just a brief diagram to show you what we can use Accupan together with. As we said, it's part of the multimodal analgesia. You can use it with non-steroidal anti-inflammatories. You can use it with paracetamol. You can use all these three together if there are no other contraindications. And by doing so, you're able to decrease your morphine or whatever opioid you're using post-operatively. Most commonly it's morphine, but nowadays people are also using oxycodone and pethidine. Some hospitals have actually withdrawn pethidine. In Nairobi Hospital, we still have it, so we still use it. So you can use it to decrease the amount of morphine or pethidine, whatever you're giving. The drug which we use if we have hyperalgesia is low dose of ketamine, and Accupan has a positive anti-hyperalgesic effect. It has a synergy with ketamine in that regard. So it will cause some degree of pain relief as well as prevent the hyperalgesia. Next slide. So just to summarize all those things, Accupan or Nefopam is a powerful analgesic drug. It has to be given slow intravenous infusion or deep intramuscular injection. Deep, because otherwise they complain of a lot of pain. You can combine it as multimodal analgesia, both with non-steroidal anti-inflammatories, paracetamol, morphine, and very low dose ketamine. It's good for most of the surgeries. It prevents the anti-hyperalgesia. It also prevents post-operative shivering, and it is very kind to the respiratory system. It does not decrease either the rate or the tidal volume, so your oxygen levels remain okay. The gastrointestinal mucosa, you can see, is also well respected. You do not have any episodes of GIT bleeding. Next slide. Just basically a summary now, and basically we said now multimodal analgesia is the way to go, so that we can reduce the opioids and reduce the non-steroidal anti-inflammatory drugs depending on patient, which type of patient you're dealing with. By doing so, we are not only lowering the dose, but we lower the side effects of each and every one of those drugs. And the aim of all this is to use minimal opioids as far as possible. There are many patients nowadays we are doing without using opioids, and they go home after big operations without opioids. Believe it or not, it's possible. Then the other thing to remember, please don't think that everything is to be given as injectable analgesics. Please continue with your local anesthetic infiltrations and blocks wherever you can, whatever you're comfortable with. But depending on the type of surgery, whatever you can do to give your local anesthetic blocks, it will go a long way to decrease any type of analgesics post-operatively, the dosage and the frequency. Number 3, remember that what we are all aiming for is to make this patient recover quickly after surgery and to go home quickly from hospital. There's this big thing going on. It's called ERAS. We were part of that group to do that. ERAS means enhanced recovery after surgery. And basically what they were talking about is patients who get very minimal opioids. You deal with pain in many different ways, including local anesthetics, blocks, non-steroidals if possible, Accupan, and try to avoid opioids. Number two is to both ambulate these patients quickly, remove their NG tubes quickly, let them start taking oral sips and oral liquids quickly. They walk around quickly and they go home quickly. And that is what all of us are trying to do now. Even in the past, if you remember, a cesarean section could stay in hospital for 5 days to 1 week. Nowadays, there are many going home after the first day, and most of them on the second day after operation, they're home. And why is that? Better pain control, earlier feeding, lack of gas, and you don't give them opioids so that their stomach gets, their intestines get lazy. They move around quickly because you have taken care of their pain. You take care of their vomiting, they feed quickly, and they go home quickly. There are many patients who are not even using opioids, even for cesarean sections, believe it or not. Okay, next slide. Next slide. Oh, that's it. Okay. Hello.
Yes, thank you very much, Dr. Moniz, for that
thank you, Sarah.
presentation. Yeah. Thank you very much. At this point, we would also like to ask Dr. Hala Zahaf, who is a pharmacist from France, to present on the molecule Acupan. He's a global medical advisor for Harleys. And in the meantime, please drop your questions in the chat box and we'll go through them at the end. Thank you very much.
Hello, everybody.
Hello, welcome.
Thank you very much. Hello, everybody. I'm Hala. I'm pharmacist from Biocodex, French laboratory. I am the global medical manager for Acupan globally. And today I'm going to present to you, I'll do this presentation to let you know about the clinical studies with Acupan and the proper mode of administration. So first of all, I would like to thank Dr. Moniz and Dr. Okiya for giving us this chance to present Acupan, and our local partner Harleys for giving me this chance to present you the product. So first of all, I put the chemical structure of Nephropam. So Nephropam is, sorry, I have the video. It's very here. So Nephropam is benzoxacin, which is an analog of orphanadrine. So the therapeutic class is analgesic, and the main indication is acute pain, including post-operative pain. So we have it in ampoule, vial for injections, and we are present in more than 57 countries over the world. So it's widely used and it has been used in France for more than 40 years. So as Dr. Moniz said, Nefopam or Acupan has a central action with action on spinal and supraspinal level in the central nervous system, and it has no action upon opioid receptors, so it doesn't bind to mu receptors, and it is not an opioid drug. It has analgesic properties by intensifying the descending monergic inhibitory pathway. I don't know if you can see my mouse. I can maybe show here. So it acts on the inhibitory descending here in green pathway on the central nervous system, and it blocks the monoamine recapture reuptake, which is serotonin, dopamine, and noradrenaline. So the good news is that it doesn't bind on the serotonin 5-HT3 receptors, which means that you can combine it with citron. We have here an clinical study with ondansetron, but also ramosetron to prevent nausea and vomiting during post-operative pain management. So you can use it. You can use it with citron with no worries. So it has another anti-hyperalgesic properties by decreasing neuron excitability. So it's going to block the voltage sensitive sodium and calcium channels and decrease the glutamate release. Uh, and by decreasing the stimulation of NMDA receptors, we will have an anti-hyperalgesic mechanism, as we know that the NMDA receptors are involved in all type of hyperalgesia after the use of opioids. Another property of Nefopam is an anti-shivering properties. So Acupan acts centrally by decreasing the shivering threshold by 1 degree Celsius. So this is an option for you to avoid shivering post-operatively by using Nefopam. And you can see in a meta-analysis published in 2012 that Nefopam has been ranked best drug in preventing post-operative shivering. And here, comparing to the other drugs that you can see here. So it's one of a property that is for us good for patients. It has also with different clinical trials, we here I summarize some of the clinical trials in opioid sparing effects. Here it's for morphine, and you can see that we can spare from 22 to 50% of morphine dose in different kind of surgery by using Nefopam. So by combining Nefopam and morphine in multimodal analgesia, you're going to reduce the use of morphine, but also other opioids, as Dr. Moniz explained to you, and all the side effects of opioids and other analgesics. So here I put a table that with different kind of combination of Nefopam with different analgesics. So for mild to moderate pain, you can combine it with NSAID and you'll have better analgesic synergy. And with Parecoxib, you can have a better analgesia. With paracetamol, you can combine Nefopam with paracetamol for moderate pain, and you have a synergy in analgesia. And for severe pain, you can combine it with opioids and non-opioid options. You can combine it with morphine, fentanyl, oxycodone, Remy Fentanyl, and you also can combine it with non-opioid drugs like paracetamol plus NSAID, and you will have a super analgesia comparing to the morphine arms, and you will have less side effects as you consume less morphine. Here another slide to let you know about the different clinical studies we have with Nefopam. So you can use it in different type of surgery. We gave you some example here, but they're all clinical studies. You can use it in pneumology. You can use it in breast cancer surgeries, gastroenterology, orthopedics, urology, gynecology, cardiology, but also ENT surgeries. So it's safe, and we can provide you with all kinds of clinical studies in different surgeries. So you have a wide choice with Nefopam. We wanted to share with you the latest international guidelines as now with the COVID-19 patients, different medical societies recommended Nefopam to reduce opioid use in COVID-19 patients in critical care units to avoid respiratory depression, but also other side effects. So we have here the Society of Critical Care Medicine, which is an American international society. You have here the SFAR, which is the French Society of Anesthesiology and critical care medicine. And also recently, this is in 2021, we had new guidelines with the Colombian Society of Anesthesiology and Critical Care Medicine. For the safety, Nefopam doesn't have action on respiratory function, doesn't have action on blood coagulation, doesn't have antipyretic effects, and we have a very high therapeutic index, so you can combine it with different kind of of drugs with great security. Of course, as any other drug, we have side effects with Nefopam, and the most frequent side effect would be nausea and vomiting, sweating, local pain at site of the injection, dizziness, tachycardia, urine retention, and dry mouth, and it can increase the pressure in acute angle glaucoma, as Dr. Moniz explained to you. But what you need to keep in mind is that side effects occur when we have a very fast infusion or administration. So what we recommend is to use a slow IV infusion with Nefopam over 30 minutes. We can use it until 1 hour to avoid the side effects that occur when we have a speed a peak, plasmatic peak. So you have here the risk factors for those side effects, the speed injection, as I told you, the injected dose, of course, and continuous versus discontinuous. For some contraindication, Nefopam is not indicated in children below 15 because we don't have clinical data in children. It's contraindicated in people who has convulsion of past history of convulsion or seizure. Patient with erythroprostatic disorder because of the risk of urinary retention, patient with acute angle glaucoma, and pregnancy and lactation. Some precaution of use, you need to use it with precaution in patient with hepatic insufficiency, patient with renal insufficiency, and elderly patients. And you need to adapt the posology for patients who has tachycardia. As I told you, tachycardia is one of the main adverse effects of Acupan, and you need to be cautious with the people who has tachycardia, but you still can use it in cardiac surgeries to prevent pain from cardiac surgeries. If you have patients with clearance less than 20 milliliter a minute or dialysis, you divide the dose of Nefopam by 2. So this is very important to keep in mind. For the posology, as I told you, we want to have a pain. We want to have the analgesic effect before the wake up of the patients. So we advise you to administer Acupan 30 to 60 minutes before the end of the surgery, an ampoule of 20 milligrams, and then in the PACU or the care unit, post-operative care units, we recommend slow IV infusion every 4 hours. The IV could be from 30 to 1 hour for small bags or big bag infusion if you like big pouches. You can combine in the same pouch for 24 hours before the administration Nefopam with paracetamol and Nefopam with ketoprofen. So you have here the different combination that you can put in the same pouch before the surgery. And if you'd rather IM administration, the posology is one ampoule with deep IM every 6 hours. So for the IV, it's every 4 hours, and for the IM administration, it's every 6 hours because the pharmacokinetics is different. And what's very important, and I insist on that, is that you need to have slow IV to avoid the side effects, which are nausea and vomiting for the most important. But also you can administer those drugs with citron to avoid nausea and vomiting in post-operative pain management. So to resume, Acupan is a non-opioid analgesic with an anti-hyperalgesic properties and anti-shivering properties. It is adapted to most of the surgeries, and also we have guidelines in emergency care patients and in COVID-19 patients. And it's one of the treatment that is very adapted for multimodal analgesia to reduce the use of opioids and their side effects. And thank you. It was my last slide. If you have any question, well, feel free to ask.
Thank you very much, Dr. Halaf.
You're welcome.
So we'll go into the Q&A session. And a number of questions are within the chat box, so we just go through them.
I would stop my presentation, sharing my screen.
Oh, sure.
Okay.
So these on to Dr. Moniz,
Of course.
lecturer. From Henry Bukwira, why are the reasons some hospitals in Kenya have stopped the use of pethidine? Dr. Moniz?
Yes, can you hear me?
Yeah, sure.
Yeah, quite a number of hospitals stopped it. The main reason being that there has been a worldwide trend to remove pethidine because it's slightly higher risk of addiction, both among hospital staff, but also patients who keep on coming for repeat surgeries. Now, historically, pethidine was the favorite drug used by midwives in obstetric analgesia. And for years and years, it has been used. And in fact, that is why even at Nairobi Hospital at a time, it became very difficult to get it. But we insisted and we got it. But some other hospitals in Kenya are not able to get it or have decided not to get it. And that is the reason pethidine is not there. On the other question, somebody had asked about oxycodone. Oxycodone is available at most of the private hospitals. It comes as 10 milligrams and 20 milligrams vials. We have been using it also with good effect, but again, it has a higher, high degree of addiction liability. So again, it's used like a control drug. I don't know if anybody else has similar sort of experiences. I'm just telling you what we have seen here. Maybe not very scientific, but that's what has happened. Any other question? That Sarah,
Thank you.
was there something?
Yes. What is the place of steroids in multimodal pain management? From Shuaibu.
Good. Steroids will definitely help with their anti-inflammatory effect. But again, most surgeons would not like you to use steroids for more than 24 hours after operation. The reason being that it makes patients more likely to get wound sepsis and other infections. And number two, steroids, because they are anti-inflammatory, will actually delay healing. So although they may have a good anti-inflammatory and pain-killing effect, they will actually delay the wound healing. So if at all you're going to use steroids, use it only for the first 24 hours, and especially try to avoid it in people who have peptic ulcers, who are diabetic, and things like that. You might upset their blood sugars as well. So a lot of us use the steroids, especially like something like dexamethasone, both for its anti-inflammatory, anti-emetic effect, but it will also help you with pain. When there's less inflammation, there's also less pain. But again, not for used for longer than the first 24 hours.
Thank you very much.
I hope that answers. Yes.
There's another question from Dr. Nganga. What would be the ideal post-op analgesia plan for a post-CS patient going home on post-op day 2?
For a CS patient?
Yes, day 2 post-op going home.
Going home, yeah, okay. If the patient is going home and they have no kidney problem, they're not hypertensive, they're not preeclamptic or anything like that, what we normally do is we give them a combination of non-steroidal anti-inflammatory drug along with paracetamol or sometimes Panadol Extra. Panadol Extra has got the caffeine in it. Some people use Betapin. Betapin would have codeine in it, but now that one causes a lot of problem because of the constipation. So if at all you're going to use Betapin, please use with lactulose or Dalcolax or something like that, so that constipation is avoided. Constipation is a big enemy of post-op abdominal surgery. It can cause you to develop a lot of gas, and you even can develop into a syndrome called Ogilvie syndrome. I don't know if any of you have had the misfortune of dealing with a patient with Ogilvie syndrome on the second and third day post-cesarean section. You have to rush them back to theater just because the cecum is full of gas and they're completely obstructed. And you have to actually end up with a laparotomy just because of that. So your choice of pain control medication post-operative for abdominal surgery makes a big difference to the recovery of this patient. Acupan, unfortunately, is only available as injectable. And in this country, we don't like sending patients home with injections. So we use it only during hospital stay. So as I said, we'll use a combination of paracetamol, a non-steroidal anti-inflammatory, and sometimes a muscle relaxant can also help these patients. If you're going for the non-steroidal anti-inflammatories, it would be a good idea to choose the COX-2 selective, the etoricoxib or celecoxib, rather than the usual non-steroidals, just because of the lower, better side effect profile. But remember, they're still non-steroidal anti-inflammatory drugs. In spite of being safer, they're not 100% safe.
Thank you very much.
Question?
From Ibrahim, what is the place of magnesium in surgical pain management with opioid sparing technique? The place of magnesium in surgical pain management.
Yeah, the pain, what we normally do, we would give them multimodal analgesia, especially for the first 48 hours. That would include paracetamol, a non-steroidal anti-inflammatory, and a weak opioid like tramadol. We'll give them strong antiemetics and then Acupan. Some places would put them on a low dose of ketamine infusion. We have not yet had to do that, but sometimes in the theater itself, not in the ward, in the theater recovery, sometimes you do put a small dose of ketamine infusion to avoid the hyperalgesia. If a patient is going to a place where they're going to be fully monitored, then you can up your dose of medication, which is different. But if they're going to an ordinary ward setting, we prefer to use either a combination of all these as multimodal analgesia. If you have the resources in your hospital, you can also use these as continuous slow infusions using an infusion pump. Something like Acupan can be given as a very slow infusion continuously for the first 24 to 48 hours. Some people don't have enough pumps. Sometimes we include these things in the usual intravenous fluids which patients are getting anyway. Post-operatively, they get their bottle of Hartmann's or Ringer's lactate or dextrose and saline, whatever you're using. You can put your analgesic in there. They're still compatible. You can put your Acupan, and you can put your tramadol, and you can put your Placil inside that infusion to run slowly. I hope that can help you. And remember, a lot of patients nowadays are taking orally much sooner than before. So even after 6 hours, the cesarean section patients are already having their first dose of oral analgesics, along with a PPI, along with laxative, and along with something for acid. And quite often we are using domperidone as part of the treatment management for cesarean sections for two main reasons. One, it will improve their gastric emptying. Number two, it also helps them to produce milk for lactation. So domperidone, please use it for all your cesarean sections post-operatively, and start letting them feed a bit of liquids at least quickly, and take enough painkillers orally, and that way you can avoid opioids. It's possible. Even I thought it was not possible until you try using it, and you'll find your results are actually good. You'll actually write your rescue medication of opioids, but you'll find the nurses have no reason to even give the opioid because the patient says, what is that? I don't want, I'm not in pain. Okay, any other question?
Yes, sure. Could you kindly comment on the use of intrathecal opioids, particularly morphine, and use of Nefopam?
Yes. Now, intrathecal opioids, commonly we give that for cesarean section. In the past, we used to give morphine and pethidine, but it used to cause a lot of itchiness. Nowadays, we prefer to use fentanyl. But again, what I've noticed is that the lower dose of fentanyl I use for the intrathecal injection, the less episodes of hypotension I get. I don't know if it's just me. It has not been reported by everybody else, but that's just my general feeling. So I'm a bit, I go sparingly on the opioids, and I would rather give them as soon as the baby is born. You can even give it intravenously if so required. But I'm a bit sparing on intrathecal opioids, and if at all, it's a small dose of fentanyl. Pethidine and morphine do cause a lot of itchiness to the patient, and they feel uncomfortable. Any other question?
Yes, sure. What is the best analgesic management for COVID-19 patient for emergency CS?
COVID-19, okay. Best analgesic here again. These patients are all done under regional anesthesia. You would avoid any respiratory depressants. We've done quite a number. We will again used Acupen first 24 hours. After that, if the patient is not having any other problem like high blood pressure, kidney disease or anything, and we keep them well hydrated, we use a non-steroidal anti-inflammatory along with paracetamol and sometimes supplemental caffeine or codeine. But codeine now we are avoiding again because I told you because of the constipation. And main thing is to mobilize these patients quickly, take care of their pain, their vomiting, and give them a stool softener right from the beginning. It's preemptive. Don't wait for them to say they're constipated and bloated and then start rushing to give them a suppository. It won't help you. Do it preemptively. Assume that they're going to get constipated right from the beginning, from day 1 or day 0. Same day after operation, along with all the oral medication, they're taking a stool softener right from the beginning. And as long as they're on IV fluids, you can put some Acupen inside that drip. Any other question?
Dan Hussein is concerned that you said that NSAIDs delay healing. So initially he thought it should be used only 24 hours post-op, but he's surprised that patients can be discharged on NSAIDs.
Yeah, I said, if you look at the wound healing, there has to be some degree of inflammation. When a wound is trying to heal, what happens is there's inflammation, then it heals. Now, if you block that pathway right from the beginning, you're going to delay it slightly, although you don't want to block it completely. So it's more of a theoretical concern. But I know that steroids would, particularly a steroid because of its stronger anti-inflammatory effect, would delay the wound healing, and also they do cause a higher rate of infection. I don't know if that is the general consensus anyway nowadays. If at all you have to use steroids, you use it only for the first 24 hours and you remove it soon after that. Yeah.
Okay. Thank you very much. You can answer this one, and also we'll request Dr. Halaf to comment on it.
Yes.
Nefopam has been blacklisted in the UK. It's not clear why it's been removed from acute pain protocols in many NHS hospitals. Could you explain why this has been done, yet is still being recommended for surgery?
Yes, well, in the UK, we don't sell the injectable form. So we're not selling Acupen as an injectable form in the UK, and there is only the tablets. So we're not aware of the tablets in the UK. So I have no idea why it has been blacklisted. Maybe because of I know that had a price issue in the UK, maybe for that. But to be honest, I can't tell you. We're not in the UK, so sorry.
All right, thank you. I think there are some participants who are asking something about oral Acupen. So we've been ably told that it's available in injectable to be given as IM and as IV. How affordable is Nefopam in US dollars?
Maybe I can let our our partner, Rosemary. Maybe she can. I don't have the answer for the price. Sorry, I have no idea of the local pricing.
Thank you, Dr. Hala. Nephropam, currently the trade price is 750 a pack of 5 vials, direct from Harleys.
150.
750 in
A
what?
pack of 5.
What currency, please?
Kenyan shilling. Sorry.
All right.
Yes.
Thank you very much. I think most of the questions that were in the chat box have been handled.
No, there was Dr. Sarah, there was a question about, maybe Dr. Hala can answer that, about if Acupan can be used together with lignocaine to prevent pain at the point of injection.
Yeah, sure.
Well, there is a pain at the injection site, but I don't think it's necessary to have a local anesthetic to reduce it. I mean, it's normal pain, like other type of injected medicines. So I don't know. You can use it, but I don't think that it's necessary to use local anesthetic to avoid this kind of pain. I don't know what Dr. Moniz think about it.
I think only for a very, very fussy patient. But if you actually give it very deep intramuscularly using a thin needle, usually then the pain is less. But some of them object to putting such a deep intramuscular. When it is given in a bit superficially, it is painful. That there's no doubt. And that's why sometimes we just put it in the infusion, which is running in any case, and then they don't complain.
Yeah, deep IM to avoid pain at the injection site, but I don't think it's local anesthetic unnecessary for that.
What's the maximum dose per day, and is it recommended for fibromyalgia?
Well, the recommended dose daily is 120 milligrams a day, which is 6 vials or ampoules. So yeah, it's the maximum you can use. But usually, what we have from the different clinical trials, the usual dose used is 80 to 100 milligrams, but you can go until 120. And if it's acute pain, I would say yes. Nefopam has only indication in acute pain, and you can use it for different type of pain. So for me, there's no contraindication in fibromyalgia pain. Yeah.
Right.
Is
Acupan compatible? Is it compatible with all IV fluids? Yeah.
Yes. I've used it in both Ringer's lactate, normal saline, and dextrose in saline, and there's no precipitate, and it works okay.
So as I mentioned in my presentation, you can mix it with paracetamol and ketoprofen in the same pouch 24 hours before, and it's still compatible for like 24 hours and with the same dose. I mean.
Yeah. All right. So thank you very much for the insightful presentations and the discussion. One more thing, the guys are asking about the presentations that are available in the anesthesia platform. If you go to www.anesthesiakenya.co.ke/webinar/, you should be able to find it. But so for today's presentation and the last, CPD points will be sent to your email address for the local doctors, and for the other participants, certificate will be sent to your emails. And sincere apologies from the team. Maybe we can give Dr. Nabulindo a chance to give some announcements from the KSA desk.
Yeah, hello all, and thank you very much. On behalf of the Executive Committee of the Kenya Society of Anesthesiologists, we would like to express our appreciation for your continued patronage for this weekly activity. To bring to your attention our annual conference, the 28th KSA and 8th Critical Care Society conference is coming up on 18th to 20th of August, and the conference is fully virtual. We are inviting you to register for the conference and join us for this very interesting and extensive educational scientific conference. So you can visit our website through the admin at anesthesiakenya.co.ke. I've written that on the chat to be guided on how to register for the conference. And also for any questions, if you're getting any problems, then you can feel free to get in contact with the Secretariat through our email address and our phone numbers. Thank you very much, and we hope to see you at the conference. Back to you, Okiya.
Thank you very much, everybody, and I'll see you. If you have any question, don't hesitate to ask. So we might respond. We will respond you later.
Thank you very much, Dr. Halab and Dr. Moniz, and the participants for taking your time to go through these insightful discussions. Please find the additional information in the websites as shown in the chat, and have a lovely evening.
Thanks.
You can leave at pleasure.
Bye-bye.
Bye.
Bye.